All right. Well, good morning, good afternoon, everyone. We welcome to Department of Psychiatry Grand Rounds, our John Romano clinical rounds. I'm Mike Scharf. I'm the psychiatrist in chief of Calisano Children's Hospital and associate chair of the Department of Psychiatry for Children and Youth. And it gives me great pleasure to be here today as part of the team that's going to present to you about Brighter Days Pediatric Mental Health Urgent Care. And consistent with the long title as well of the clinical services, we have a long list of presenters. So I'm going to briefly introduce them now, and then we're going to get into the program. A couple housekeeping points. If you're watching on Zoom, please use, and you want to ask questions, please use the Q&A function, not the chat, as the Q&A is what we're going to look at to answer questions at the end. If you are in the audience live, when we get to questions and answers, please use the microphones. We'll have staff helping to make sure that those are available as people ask questions. Again, it gives me great pleasure to be here today to talk about this exciting new service and program, which is really making a big impact on our community already. Joining me are my colleagues, first Dr. Linda Alpert-Gillis, who's a professor of psychiatry, pediatrics, and nursing, and has been a colleague to me for many years and a mentor to many of us here in this room. And I imagine, though I can't see your faces, those watching on Zoom as well. She's currently the director of all of our child psychiatry ambulatory services, and she's our division chief for child and psychiatry ambulatory. She also oversees the laboratory for mental health interventions and innovations in children and adolescents. Dr. McKenzie Smallcomb, who is our clinical coordinator for the Brighter Days Urgent Care. She received her doctorate this past year from U of R in the Warner School and has been a clinician in our ambulatory clinical services now and been a very valued, not only a clinician, but leader, particularly around our START services and now in her new role with the urgent care. Dr. Segundo Robert-Ibarra is our division chief for acute services in child and adolescent psychiatry. He comes to us as a political refugee from Texas and has had a number of experiences before coming here in clinical care, in leadership, and in education. And he's not only in that sort of higher up chief level role, but he's also the medical director for the Brighter Days service. And Leah Ward, Dr. Leah Ward is our faculty psychologist in the Brighter Days service. She's a senior instructor in psychiatry, and she did her postdoc fellowship training here at U of R before joining us as faculty. So very excited to get this started. Before I give the floor to Linda, I want to get us started and thank a few more people. This service that we're going to talk about today, this Brighter Days Pediatric Mental Health Urgent Care, is a new level of care for our region. It's only the second of this type in New York State. Very excited to see it come about and come to completion. We cut the ribbon and started seeing patients at the end of June, beginning of July. We started walk-in visits in mid-July. And as I mentioned earlier, we've already seen some significant impacts on the community, which we're going to cover today in greater detail. But before we get into those details, I do have some thanks to make. The first is to our friends at the Brighter Days Foundation. As the name of the service implies, none of this would be possible without their generosity. There's also some individuals and families that have been significant contributors to all of our advances in child psychiatry services in the last 10 years, and specifically for this one. I list them on the slide, and they include Mark and Maureen Davitt, Don and Leslie Tomini, Jeff and Patty Davis, Art and Judy Finichario, Tim and Susan Fournier, Todd Levine, as well as our friends at Bank of America, and of course, Tom Golisano, for whom the Children's Hospital is named. And I also want to say a thanks to our URMC leadership. While we've done a lot of things thanks to philanthropy, it's also true that none of it would be possible without a leadership that is committed to the vision. I do, for real, every couple of months have conversations with other institutions that talk about, well, how did you raise money and how did you do this and how did you make it real? And one of the things I always say, not just for this service, but for others, well, the university matched whatever big gift we're talking about. And that's actually ended some of these other conversations. So I really sincerely want to thank our leadership. We have a big team presenting today, but we're also part of a broader team, including community members who supported addressing mental health needs in our community, as well as the other clinicians and staff that work with us. And a side note, if you will, as we're talking about this new service, simultaneously with opening the urgent care, we reopened the Ronald McDonald House Charities Family Lounge, which is located right next door to our urgent care. And as part of that reopening, this was dedicated to Dr. Patrick Brophy, previous chair of pediatrics and a close friend who was part of that leadership that was so committed to advancing our mission to ensure that every child has access to quality mental health care when they need it. So my thanks in memory to Dr. Brophy and to Joanne Ryan and all of the people at Ronald McDonald House Charities who've helped make this vision a reality. And with that, I'm now going to hand over to Dr. Alpert-Gillis.
Hi, everyone. Good afternoon. So I'm going to just do a little bit of setting the stage, if you will, for the details about the urgent care. And we're excited to share what the service includes and also some of the data, even though we just opened in mid-July. So it's very early for us, but we have lots of interesting things to share with you today. So as you know, there is a pediatric mental health crisis. And we have been trying diligently to address this. As Mike said, we've been able to do that with the help of many donors in the community. And by expanding our outpatient services, we really have made a significant difference in the lives of the community by allowing much better access to services. And that largely happened with the opening of the South Ave location. However, many families are still utilizing the emergency departments in times of crisis as their default care. And we felt that there was a need to really try to close that gap. So the primary goals that we set for the urgent care was to improve access, number one, to evidence-based, high-quality mental health care for kids of all backgrounds, shapes, and sizes that are in acute distress, along with their caregivers, through a virtual and physical 7-day-a-week setting. So this was the first time as an ambulatory leader that I've ever operated a 7-day-a-week service. So my hat's off to all the people that have been doing that for a long time in terms of running a 7-day-a-week hospital. So that was a new challenge for us. And to really reduce as many barriers as we can, people are also able to access the urgent care through my chart in a virtual format. Our goal was to decrease demand on CPAP as well as other emergency departments in the area for a number of reasons. One, because to enable CPAP to deal with the volume of kids that they saw more appropriately and to decrease wait times. So part of our goal was not only to give people an alternative, but to enable care to be more timely in the CPAP setting for kids who really need that level of care. And we really want to provide a welcoming and affirming, comfortable space for youth in crisis. And of course, as most know, that it's very hard to do that in an emergency room setting. And we want to be able to provide a number of services that would meet the needs of kids in crisis, including assessment evaluation, safety planning, crisis intervention, and linkage to healthcare and educational resources. Oops, sorry. Okay. Hey, I just have to wait. I have to be patient. Um, it's really been a partnership, as Mike said, with both the community, especially the donor community, and URMC leadership. But it's also been a partnership with parents and other stakeholders. So this is a picture of a presentation that we did at the National Conference for the Federation of Families, that we were able to bring families with us to present on all the great work we're doing empowering family voice. And parents were critical in the design and services that we chose to offer within the urgent care setting. And the last thing I want to stress was the importance of a continuum of care. So in the literature, some people have commented negatively on the idea of mental health urgent care, because unlike strep throat, it's not a situation where like a one visit is going to like solve the problem. That we're going to prescribe antibiotics and the kid's going to go home and get better. We realize it's more complicated than that. And so we feel very strongly that urgent cares need to exist within a continuum of care. And so that includes our outpatient services, partial hospital, inpatient, our crisis call line team, our mobile crisis team, and yes, CPAP too. And so it's been a real setting the urgent care in the context of all those existing resources, but also enhancing our collaboration with community providers, both locally and regionally. So just to give you a sense of where outpatient services are now, it's actually 17 locations. So when I started, we had one location and it was in the space where the urgent care currently is. And that was the entire child outpatient services when I started 37 years ago. So now we have two main locations, our East River Road site, where we're co-located with Child Neurology and Division of Developmental Behavioral Pediatric. We have 3 primary care locations and 11 school-based sites. So now I'm going to turn it over to Dr. Smallcomb to talk more about the urgent care.
Hi, everybody. It's great to see you all. Over the last year, it's been really great to kind of have this vision and think of the design, but over the last few months, really been nice to see it come to life. And so we, at Brighter Days, we offer a couple of what we call like buckets of services. So one of the services that we offer is our walk-in pediatric urgent care. We also have our START program, which stands for Short-Term Assessment and Response Team. And then we also are home to our admission center. And so there at Brighter Days, we really have an interdisciplinary team. We've got folks on our case management team who can support not only our youths, but our families. We have peer family advocacy supports to really help meet the needs of the families who are walking in and those caregivers. We also have mental health therapists across disciplines. So those are the clinicians on the ground helping to support the families with evaluation and making some recommendations. We have a nursing team, both an assistant nurse manager and an RN, who's a crucial part of our team. We have psychiatric technicians, and that role is folks helping our waiting room and supporting families to feel comfortable while they wait. So we have psych techs who are helping engage families in activities, maybe sitting in our relaxation room. And then we also have our psychiatric team members, so our psychiatrist and nurse practitioner, supportive of the team and also helping to do our admissions evaluations. I also have to be patient. So really, when we had the vision of this walk-in clinic, we wanted to help families understand that our goal is to really help provide readily accessible evaluation and interventions to youth in our community who are really in some acute distress. So our walk-in services currently, as it stands, we support families 7 days a week, 12 to 7, both with in-person visits, and we're expanding our on-demand video visit option through the URMC, like the MyChart portal. And so we've really been able to see families come in right there at noon and be able to support them all through 7 o'clock. And with the expansion of the service being 7 days a week, we're able to support families over the weekend as well. So a little bit about who's eligible. And I just want to take note that this is a photo of our relaxation room, which was, we had really heavy input from our families on our family advisory board about what would be a comfortable and welcoming space. So we want to thank them for the support. We've gotten a lot of positive feedback about that room. But so eligibility for walk-ins, who's welcome to come, right? And so really it's appropriate for many families in our community. We're a service that isn't one size fits all. But so families or youth who come in who are 18 years or younger, and we recommend that they come accompanied by a caregiver so that we can help to make recommendations that are family focused and helping the family members get the support that they need to support their child who's experiencing a crisis. So while we are appropriate for many families in our community, there's a couple of criteria that our service is just not appropriate for. If we have a kiddo who comes and is significantly dysregulated, they might need a hold, a physical restraint. A locked environment is going to be a safer option for that family. We also do not administer medications on site. So if a youth is requiring that, again, a locked unit in the emergency setting is a better fit. And currently, as it stands, if a child is mental health transported, they will go to the emergency room for medical clearance. And anybody who really needs that medical clearance, so let's say there's a self-harm wound or they've reported a suicide attempt that day, we really want them to be able to get medically cleared in the emergency department. But something to note is that our PDD has been a fantastic collaborator with us, and we have lots of families who, as Linda said, they show up at the emergency department because they're looking for that care, but just don't know where to go. When they walk into the door at the PDD, as long as they're able to meet our criteria and they're able to be medically cleared, they've been a great collaborator in helping to transport families down to our service so that families can be seen in our urgent care instead. So I just wanted to toss up a little roadmap. This is really what families can expect from our service. When they walk in the door, they'll register with our front office and they'll complete some intake paperwork. It helps our team kind of get a better sense of making sure that they're safe to be in our waiting room, but also start the planning and dispo ideas right as they walk in the door to really think about what is this family potentially going to need. Then we'll triage and we'll give the family an orientation of the walk-in visit so that when they go back to the waiting room, they're all set to meet with that clinician who's going to do that assessment, evaluation, thorough safety plan. And by the end of the session, families are leaving with some recommendations and likely referrals or linkage to care. So how do families get referred to us? Well, one of the ways is that families just walk in, right? Word of mouth. Lots of our community partners are aware and helping families to learn about our service and come to our space. But one way that we're helping families in the community is partnering with our crisis call line. I want to just do a shout out to that team. They've been fantastic in working with us. They are on the ground fielding calls from our families in the community, and they do a really great job supporting families and thinking about which level of care is actually the most appropriate for them. So it helps families to decrease confusion and also not land in a space that is not the best fit for them. So they'll refer directly to us, and then they give us a heads up that families are on their way. And so if they're not appropriate for our site, it might be that they've mobilized a mobile crisis referral. That family may be better served in their home versus having to travel to us. And then I just want to talk briefly about our short-term assessment and response team, our START program. So as Dr. Alpert-Gillis was mentioning, urgent care models have been criticized for not having like embedded care in their service. And so we're lucky to have our START team. We've been existing here for many years. It actually started at our Science Parkway location, and we've expanded over the years. But we're a short-term 1 to 6 session therapy program that has expanded since the move to Brighter Days. So we've expanded our hours and also our weekend time to help meet the needs of families. So our start appointments are the only appointments at our walk-in service, Brighter Days, that are scheduled. And usually when we get referrals for that service, we can get an appointment scheduled for folks within about 1 to 2 weeks, depending on the volume in the community. So our eligibility is very similar, 18 years or younger, but our main thing is that we are interested in helping families who are really seeking that intervention because it's a short-term intervention and because those slots are very limited. We want to support families who are interested in having something short-term to get started right now. And in our START program, because we're short-term, we don't offer psychiatric medication management. So we just like families to be aware of that. So they're not coming disappointed thinking they're going to get prescriptions in our service. And so START is really most appropriate for families who need care pretty soon or pretty readily, but don't need care right this moment. Those are kids who would be better served in our urgent care as a walk-in, calling 911, or needing some sort of same-day evaluation. So START sessions are similar to our walk-in, but expanded to up to 6 sessions. So we really support kids and families in thinking about their concerns. What is their short-term targeted goal? What do they want to get from our 6 sessions? We really help families with evidence-based interventions, really involving families in that care. So giving a lot of caregiver or parenting support and doing quite a bit of safety planning with families while they're in our service, so that by the end of our intervention, we can make some recommendations if they're requiring additional care to help link them to the services that they need. So referrals come from lots of places, but our most typical ones are families call our intake team and refer themselves. Our crisis call line, again, is a great collaborator who helps kind of think about where families might be best served. Our mobile crisis team, when they go out to see a family, they have the ability to schedule into our new patient visits to help link those families directly to care. And then we are able to, when we see somebody as a walk-in, if they're appropriate for the START intervention, we're able to offer that immediate linkage as well. And I'm going to pass it over to Dr. Robert-Ibarra.
Good afternoon. My name is Dr. Segundo Robert-Ibarra, and I'm the refugee from Texas. And I think that I've been very blessed, you can say, to have come to Rochester. And I think I feel like my life has prepared me to kind of to do what I'm doing right now. So I'm the medical director, but I also to conduct a medical service or a service requires, like we know, 7 days of services. And I can tell you that I'm not alone here. I want to thank everyone who helps me by covering weekends, after hours, and we have a number of child psychiatrists, fellows, moonlighters, and psychiatric nurse practitioners who have been extraordinary in their service. And so when the goal is sort of kind of thinking as not just physicians or nurse practitioners who are going to be managing medications or doing sort of checklists. I wanted my service to also be able to be on the front line, being able to collaborate with counselors, being able to, safety plan, being able to collaborate in services, and being able to be flexible in terms of how do we conduct our services. So now we do have the capacity, which is really good, of being able to admit patients directly from the urgent care to our unit. That has been a great benefit, and also sometimes can be a barrier, sometimes because of kind of how big our unit is. At that moment, we do have to have a lot of collaboration with CPEP, and they've been great at that. Our aim in the future is to create an admission center that will be a place where we would be able to coordinate and and gives sort of a weight on who comes from, Briar Days, the Pediatric Emergency Center, CPEP, the Golisano, the consultation liaison services, and our community partners too, in other hospitals. The same thing, I'm not going to repeat what the triage does, but what our services actually, what I was surprised is actually we don't see a lot of kids that come all the way to us. But what I've asked everyone in our services to be able to be prepared to be part of the team that makes decisions and who are calm and be able to manage crisis, and for families to be heard, listen, and so we can increase the trust that they have it, so they can come back. And if this is the first time that they have having encountered psychiatrists or mental health professionals, they can begin to build the trust that actually we do a service that is helpful. One of the things that I like about our services is flexible. We can have a crisis today. They may not be ready to be admitted, or we may develop a plan that requires, for example, sending them home. And the family can change their minds. They can, the level of crisis can change in a few hours, and they can come back, or they can come back in 2 days, or we can develop a safety plan for one night if the services, if our inpatient service is full. So it gives us that flexibility, and that reduces, I think, a kind of the trauma of having to wait for hours at our other locations. Future admission centers are hopefully, prioritizing admissions and making that flow seamless. So I think these are things I already said, which is, using our providers in terms of all their competencies, just not psychopharmacological competencies, but also the capacity to have dialogues, to decrease the level of anxiety, to feel safe, and to increase their capacity to think, problem solve, and reduce the crisis. I wish that our families leave feeling understood and feeling contained and taken care of. The risk is that they will come back, but that's that's not a problem. We want them to come back, and hopefully then we can establish longer term care for them. Right now, what is the staffing like? There's one medical director and numerous helpers in terms of family, psychiatric nurse practitioners, and moonlighters. And we're going to have a full-time nurse practitioner who's going to be coming with us, Natalie Lynch. I think January she will be fully with us. We offer also consultations for the certain start kids who are somewhat connected with their primary care doctors. We can meet with them, we can evaluate them for an hour and a half, and provide certain recommendations to the primary care doctors who are willing to continue managing their medications, or sometimes give recommendations that this child may need a higher level of care. And we have also found that we collaborate with other specialties like neurology, or doing certain services that in the past were not able to be done in the emergency department. So ultimately, we want to kind of decrease any trauma that a family may endure during a crisis, and be able to facilitate, for example, the admission process. And I now pass to Dr. Ward.
Right. So I will be going into the data that we have collected so far at Brighter Days from when we opened in mid-July to beginning of December. We serve patients and families from a wide region, including more rural and urban underserved populations. And as you can tell, we have seen patients from counties that have been 1 and 2 hours away. The diversity of the families that we see is representative of the population for this region. Going into the walk-in clinic, the referrals that we get are mostly from the crisis call line and patient's primary care physician, and many families self-refer. They walk right on into our clinic to get that immediate access to care. When viewing the presenting concern for why they are visiting our walk-in clinic, the main ones are concerns for suicide, emotional or behavioral dysregulation, anxiety, and depression. Looking at when we opened in mid-July till now, we have been steadily increasing in the number of patients that we have been seeing. The busiest month that we have had so far is October, and we have had a little dip that was anticipated in November due to the holidays and looking at data from the other services that we have in pediatric behavioral health and wellness. Our busiest days of the week are Monday and Wednesday, and our slowest days are the weekend. And that is likely representative of patients being in school and when some of those crises can occur. As I'm gonna go ahead and reiterate, we open at 12 and we close at 7 for our walk-in clinic, and our busiest hour is right when we open at 12, and we steadily trickle down as the evening hours go on. We have seen patients as young as 3 years old all the way up until 18 through our walk-in clinic, and we primarily see teenagers, as you could see represented within this graph. And since we opened in mid-July, we have been able to directly admit 35 patients to the child and adolescent psychiatric inpatient unit, decreasing congestion within the PEDS ED and CPET. Anecdotally, patients and families have reported satisfaction with ease of access to our services, with connection to appropriate referrals and services within the community and URMC, and with the speed at which they can be admitted to the inpatient unit if there is a bed available and if it is appropriate for them. Community partners have expressed satisfaction with our collaboration and with their ability to refer their students, children, youth, all to us. They have relayed comments that they have received from patients and families who have visited us, and they have mostly revolved around the welcoming and comforting atmosphere within our clinic and the referrals that we are able to make for them, as well as the just kindness and interactions that our staff has had with those families. And that's why they keep coming back to us. All right. When looking at the future of Brighter Days, we are working towards increased promotion of our video visits to increase access to care for those families who might not be able to otherwise access behavioral health services. We are looking to obtain more standardized measures to assess patient and family satisfaction of our services. And we are going to continue collaborating very closely with the Family Advisory Board to incorporate their feedback to make improvements to the services that we can offer at Brighter Days. All right, thank you for your interest in Brighter Days, and Dr. Scharf will now be facilitating the Q&A portion of this presentation.
Thank you, Dr. Ward. All right, I'd like to actually ask the whole team to come on up here. We're gonna have a panel discussion right now. As they're coming up, I'm going to add a few comments. Add a few comments of my own, which may facilitate discussion or questions. Some of which I'll be emphasizing points that have already been made. This doesn't work if it's not embedded in a system. If people are hearing this talk thinking about launching similar endeavors, you don't necessarily have to run all the elements of that system, right? We happen to have the only inpatient, only partial, largest outpatient service, et cetera, but you do need to be embedded in a system. And so I think that's one of the things that we knew and is really being reinforced for us and in comparison to other places. Access to mental health care and challenges, what people have referred to as the pediatric mental health crisis, is a community problem that requires a community solution. And I would suggest that that's what you've heard about today, is really a community solution. Dr. Alpert-Gillis talked about the importance of family input to drive how we made structures, even as Dr. Smallcomb said, the space configuration was largely influenced by families. I think while this is still preliminary in terms of looking at feedback and results, I think this is proof that you can do that. We have a history in healthcare, not specific to mental health, to design services, and the input we get from the public is to evaluate or help us with quality improvement after. I think what you've seen and what I'm happy to talk about now is an example of including that community member and family input in design. And again, I think that that's starting to pay off. All right, we're going to transition to the Q&A. I have a couple questions that have come in from Zoom, and if there are people attending on Zoom that would like to ask more questions, use the Q&A function. And is Sean going to be with the microphone? For people internally, I'm going to ask one of the questions from Zoom first, but raise your hand if you'd like to ask a question, and Sean will get you a microphone. Oh, thank you. Okay, the first question is, for those who come for START, how do they connect to someone for prescribing? McKenzie, use the microphone to answer.
Yeah, that's a good question. So we have a couple of options. One of the things that we help encourage families to do and in our consultation is connect with their primary care physician. A lot of their primary care physicians, with the support of our team and even a consultation with our psychiatric providers, may feel comfortable in helping to have families start on medications. If the primary care provider is not able to prescribe, or they would like an opinion or have somebody to get started, we do help to provide recommendations for providers in the community. And that's one of the things that we do throughout the 6 sessions. So if that is one of the primary goals for families, we'll help to provide them with a resource list, support through case management to kind of think about what services are available near their home or with their insurance. So we make referrals.
And I really love how McKenzie jumped right in on the meaningful long-term plan. A key part of that answer is also we have dedicated time for psychiatrists to support START every week as well. All right, I think George has a question.
Thank you very much. A wonderful service, wonderful presentation. My question, actually I have 2 questions. My question first is, one of your stated goals when you started was to decrease the pressure on CPAP and to provide alternative to families and patients. So are we measuring that in some way? One of the criticisms of urgent care in general is that it doesn't really necessarily decrease pressure on EDs, but creates a separate service of its own. So are we measuring that? And
I'll take that one. And partially because I want to acknowledge on behalf of the department and the institution, we don't actually have an adequate system in place to answer that with data that I can be 100% confident in. Why? Well, it has to do with how and why people come in. And we don't actually, our data doesn't track voluntary versus non-voluntary presentations, which is bizarre, but right now that's still true. I hope within the next quarter, that won't be true anymore. From chart reviews, which are dependent on me actually opening eRecord and looking at every chart, we actually have almost eliminated voluntary presentations, which is pretty cool. So again, it's not quite the same as having a solid eRecord report audit, but by my visual review, we've almost eliminated voluntary presentations, which speaks to communication and how people come in, but also what you heard about before, our pediatric ED nurses really giving people a heads up that, hey, you don't have to come upstairs and wait for 24 hours to finish your eval, which is, I think, our average time still. You can go over this alternative urgent care. So in terms of process, in terms of big picture, what we can track and get a feel for, we've made a big impact. In terms of the experience in CPAP, there's still kids in CPAP. This morning there was 7. However, they'd all been seen. They were all, 2 of them are what we might call stuck or abandoned because topic for future grand rounds, children in New York State don't have the right to safe housing. But 5 of them have just been seen and haven't actually been discharged yet. So we've made an impact, but we're not all the way there. Our next online question, so glad to hear rural families are using this. How is this being communicated to rural communities and providers? Who would like to take that one?
Yeah, so we have actually gotten lots of outreach from many of the kind of surrounding counties, from pediatricians' offices, school districts. So we did a lot with our marketing team in the beginning to help have brochures and those kinds of things for families to really understand. And then what we're sharing with all of our community partners who really know those families well is reminding them to call our crisis call line first. It will help them kind of triage and think about, is this a family who would benefit from traveling, let's say, the 2 hours to our service, versus is there something that can really support them without having to do the traveling? So I would say a lot of the communities in our surrounding area are aware, but I definitely think there are folks who would benefit from increased awareness of our service.
Great, thank you. Yes, thank you, Sean.
I think I just want to piggyback on that question. If we're looking to broaden with virtual walk-ins, how are we going to train our people to know more of the resources in surrounding counties to be able to help them?
We actually have quite a bit of information already about surrounding counties because our outpatient services are really a regional service, not a local service. And so we currently get referrals from Pennsylvania, from Watertown, New York, from Ithaca, like all the surrounding counties and beyond. And so our case management team, led by Gerard Johnson, has done an amazing job of building a community resource manual that is updated regularly. So when someone calls us, the intake team doesn't just say, you're 3 hours away, we can't help you. We give them resources that are as close to home as possible. So we already have that resource available to us. And so we're able to tap into that not only when people call our outpatient service, but all the different parts of our outpatient service.
Excellent. Our next question from Zoom, what does the discharge planning look like for participation in START program, since it's a short-term program? And do we offer assistance in connection with long-term providers?
So the short answer is yes. Throughout our 6 sessions, we really think about what might the family need. And so there actually are a lot of families who really feel a sense of stability. They feel like they've linked really well to their natural support. So those families are families who are really leaning on their school partners, check-ins with them. But if they're a family who really is needing additional services, we help to mobilize the referrals to outpatient services, in-home services, maybe a health home, and then up the continuum of care as well, with referrals to partial and supporting them that way.
Great, thank you. So we got a question in the audience. I'm sorry.
Yes.
Thank you. Thank you, Helen.
I had a question about your thoughts about functioning within a CCBHC model, in terms of the impact you see from a clinical perspective, how it may be similar or dissimilar to maybe your more traditional outpatient programs? I'm just curious if you could speak a little bit more to that.
I think Linda should answer that, and I'm going to piggyback on there in case you want to do it in one breath, because our next online question is, what are the fiscal challenges, which
Okay.
contributed to how we chose CCBHC?
Yeah, definitely. So it actually is a perfect CCBHC outpatient clinic because the purpose of a certified community behavioral health service, which is a SAMHSA funded initiative through New York State, is that they fund targeted case management. They fund family peer advocates. They fund primary care nursing support. So they fund rehabilitation therapy. So we're actually able to utilize all those resources in the urgent care as we do at our other CCBHC locations, which are our two main locations, South Ave, East River Road. And that has made a tremendous difference for the families that are seen in the urgent care. And when someone leaves the urgent care, it doesn't mean that they're done with us. Family case managers, family peer advocates can follow up with families after the visit to make sure that they get connected. The other thing that Mike was
Fiscal
going to point
challenges.
out was the fiscal challenges. So having a CCBHC designation means that we get a higher rate of reimbursement for children with publicly funded health insurance. So that includes Medicaid, managed care Medicaid, and also Child Health Plus. So because we have that enhanced rate, which enables us to cover those other services that I mentioned that aren't always billable with insurance companies, that really tremendously helps us be stable. Part of keeping the START services located within the urgent care was by design, both for productivity and clinical revenue stability. But also we just thought it was great to be able to say, you can come back and see me tomorrow to be in the START program. So we offer families great continuity of care by embedding START within the urgent care setting and not limiting it to walk-ins.
I think I would also add in terms of the fiscal challenges piece, there's other like CPAP bills at a much higher rate. ED visits is a higher rate. There's new versions of crisis services that have been rolled out by OMH that potentially could bill at a higher rate. But generally speaking, the rate per visit is directly proportional to the number of rules that you need to follow for each encounter, independent and sometimes directly contrary to patient and family preference. So that was a big part of our decision making too.
Yeah, and I think that's something that we still struggle with is all the, regulations of running an outpatient clinic as an urgent care service. For example, the treatment plan requirements is quite a heavy lift in an urgent care environment.
Great, thank you. The next question is, can other systems follow URMC's lead? Do you want me to take that? Well, yes. So again, with some of the caveats we already mentioned about, I would not recommend embarking on this type of level of care or service line without the community of services to connect with. So yes, or yes, but. And then another perhaps way of answering the questions. We have gotten a lot of questions, asked to see the space, hear about how we're running this from nearby institutions. There is an increased awareness and encouragement at a state level and at a payer level to provide more crisis services. So not only can other institutions follow our lead, but there may be incentives to do it.
Yeah, I just want to add that we cannot do it alone, even though we're a fairly large system and we see over 65,000 outpatient visits a year in child outpatient. We cannot do it alone. And so our connections to all those other community organizations, both locally and regionally, is critical. Another thing, if someone comes to us from another organization, unless it's the wrong level of care, we're always referring back. So when we've done our tours and gone to speak with other organizations about referrals to them or being able to see their patients in the evening and on the weekend, we've stressed that we are not after capturing your patients and keeping them all. We will be our first thought for disposition if someone comes to us from another organization, another agency, or another provider, is to refer back to that provider and give them information that we have shared with the family so we have good communication. One of the things that I feel like the team has done an amazing job with is that we're not a black hole, that after we see a patient, we are sending our notes and communicating with the primary care provider, the school with parent permission when it's clinically appropriate, and with other providers that are involved with the family's care. So that communication is key.
Great. Other audience questions? Well, raise your hand as we're reading and answering the next online one if you have questions. Can you tell us about patients who eventually receive ongoing long-term psychotherapy and where? I don't know.
You want to?
No,
you want me
no,
to-
no.
Okay. So we take a portion of the kids that we see in the urgent care, referred to our other outpatient services at our other locations. So in addition to the START program, kids can also be referred from the walk-in center for longer term care to our outpatient service. But one of the things that we have in our outpatient service is different tracks. So we have a short-term track that Doctors Hunt and Malcolm developed called the READY track, which is a short-term evidence-based treatment where kids are seen with their families for a total of 12 sessions or less. And then we have our flex track, which is more for kids that may need longer term services. So we are definitely part of the piece of that puzzle. But again, we cannot be the only solution to that because of how much demand there is for those services. So again, we're partnering with local and regional clinical agencies and providers to refer families directly to them, and when appropriate, to get priority access appointments.
Thank you. I think a useful number that might stick in people's minds for enhancing that context. How many requests do we get each week for new services, Linda?
We get over 100 from the community every week for services.
And how much is our waiting list for like the partial hospital right now? 200?
Oh, so partial hospital's different. Partial hospital has a very seasonal demand. Right now, we do have a wait list, but it's not that long, and it will go down as we get toward Christmas, and then it will pick up and continue to be as high as 12 weeks in the spring. Seeing no other audience questions, there's a question: is there a similar urgent care for adults? I'll take that one. There is not within U of R. And there's not an exact map on in our region, though the BHAC, which is a service run in Rochester Regional Health System, is a walk-in crisis service that can see adults. Again, we'll continue with the questions online. This one's actually a comment, but perhaps, oh, I'm sorry, I didn't see you, Scott, through the screen.
Yeah, quick question about the numbers. It was really interesting to see the data. So I'm just sort of curious to know what your thoughts are in coming months and years. And then also, how would this data and usage be affected by the eventual opening of our new emergency department?
My expectation in terms of looking at our data throughout the year, I anticipate that we will be a little bit slower during the summer months, and we're going to start picking up during that school year period in September, all the way throughout May, June. And that is reflective of our other services in outpatient and also inpatient as well. In terms of how we might be impacted by the opening of the new emergency department, I feel like that could be a wonderful way for more individuals to become aware and get referred to our services. I think that we have a wonderful relationship and collaborative partnership with the Peds ED, and they're one of our big referrers. We have a phone that they are able to contact us very quickly and easily. So we're in fast communication with them. So I anticipate it will do wonders for patient care and for our numbers.
And I'll expand on that. We will not, I think that the entire ED will be a less aversive environment, which is all good. And particularly for child psychiatry and for this service line, we will also be opening a separate child CPEP, separate from the adult CPEP, which will be, run with separate staff and completely separate space and much bigger space than what we have right now. So how will that impact brighter days? Well, again, the ED will be a less aversive environment, but it will also bring up questions like where should the admission center live, if you will, how to think about and further refine, the criteria for who would go to an ED setting versus urgent care. And one other thing which we did not talk in detail about, but I think is very relevant to the question we just heard is, we have a mandate, I believe, to really look at how mental health transports happen. And, we use a new language so that it doesn't sound like a law enforcement action, but it is, and it is a limitation, even if temporary, of people's rights, which if you're only doing that for a ride, I think that's a problem. And so I want us to address that. Part of addressing that will be sort of entering the policy, and a little bit the real life of doing transports. We've received a very generous donation from West Her and have a van that we can use to transport parents and kids. We're in the process of certifying all of our drivers right now, and then we will start operationalizing that. I believe that will further, the biggest change will be readier access from schools and being able to divert some of what are currently involuntary mental health transports to voluntary. And I think that's the biggest thing that's coming to change our numbers beyond just word of mouth increased utilization. Okay, it is 12:58. The remaining things online are actually more comments, and I appreciate the kind words in some of them. One talks about the complete lack of services in Genesee, Orleans, Wyoming, and Livingston counties. It is absolutely true that the distribution of resources across our region is not anything close to equal, and it's an ongoing challenge to try to make sure that all kids in the region have access to care. And the last comment that I want to bring in before we close, it asks about Project Teach and how Project Teach may be part of the planning. Project Teach, for anyone who's not familiar, is a child psychiatry access program for New York State. It's also a perinatal psychiatry access program. I'm currently the co-director, so of course Project Teach is involved in a lot of our planning. Basically what that means, if you haven't heard of a child psychiatry access program, it's a combination of education services and real-time clinical consultation in New York State. Any pediatric provider and any maternal provider can call a toll-free line and speak to a specialist psychiatrist to get a real-time consult Monday through Friday, 9 to 5. So in these situations that we had already talked about with working with pediatric providers, mostly in primary care, about continuing medication plans, if there's a need for further support or education to follow through on that, Project Teach can be a key component. Okay, it is 1 o'clock and we're going to end. I want to thank everyone for their attention. And again, thank everyone here, our colleagues and in the community for your support in this endeavor. Thank you.